All right, Sabaila Namaskar. Good evening, um, and welcome to our Poison Information Center's monthly webinar. Um, I think we have a lot of new guests today from our NSI affiliated district hospitals from different areas. So thank you all for joining. And thank you for those that have been joining over the last 9 webinars we've been doing over the last year. As you all know, just to remind you, तपाईँहरूलाई हाम्रो नेपाल पोइजन इन्फर्मेसन सेन्टरको फोन नम्बर चाहिँ 450-2011 हो 450-2011। यदि तपाईँको फोनमा छैन भने त्यो चाहिँ राख्नु होला। हाम्रो पिआइसीमा इन्टरनेसनल एक्सपर्टिजको साथसाथै 24/7 we have specialists that are there to answer your call and to help you. And so far, we have reached every district in the country, and we have been helping with very complicated cases. So thank you all that have been calling the Poison Center. And education is a big part of our Poison Center. We're building capacity in poisoning. So these are really important webinars, and we have these webinars based on what topics we find you guys tell us are important for you. So without delaying here, I'm going to introduce our speaker for today so we can get on with our talk. So today we have Dr. Natalia Swiatowiec, which I probably messed up her last name, Dr. Natalia S. She's she's finishing her emergency medicine residency at Medical College of Wisconsin and going into toxicology in Chicago. She is originally from Chicago, Illinois, and she'll be starting fellowship as Toxicon Consortium. She's really interested in global toxicology, and when she first heard about our work, she has been emailing about how she can get involved and help. And we always are excited to have future toxicologists be involved with the work. She's particularly passionate about health disparities in the context of toxicology, and she kind of works with both clinical and public health aspect to try to bridge those gaps, and that's her primary interest. So today she will be talking about a topic that is quite important to us, and almost a death sentence, honestly, when we see these cases with paraquat poisoning. So we hope that Dr. Natalia's talk will kind of help us think through how to manage a patient that presents with paraquat poisoning, and maybe if there is evidences around that that we can learn, and maybe some approaches that we can have. So without further delaying, Dr. Natalia, the floor is yours. For everyone, please put your questions on the chat. I'll be monitoring the chat, and Dr. Natalia will be able to answer that at the end. Thank you, and welcome to Dr. Natalia.
Thank you, everyone. Thank you so much for having me. It's such an honor to take part in your webinar series today and to talk about just like Dr. Carl said, a very devastating, but also very interesting poisoning, and that is paraquat poisoning. Before we begin, does everyone hear me and see my screen?
Yes, we can hear you and we can see you, and we see the screen.
Okay, wonderful. All right, so let's go ahead and begin. So, of course, we should start with what is paraquat. So that is a highly toxic compound that is used as a herbicide, usually for weed and grass control worldwide. And how it acts is, you spray onto plants. Okay. It kills plants after it's absorbed through the leaves. And actually, interesting enough, once it hits the soil, it becomes inactive. So it actually does not affect the plants that later grow from that soil in the future. So it acts particularly on those current plants that you administer it to. It was discovered in the mid 1800s, but it's been used for commercial use since the mid 1900s. I should say we say it's used worldwide, but actually since these times, there have been several countries that have banned paraquat for its poisonous process within the bodies, or there are countries that have, put it under restricted use. So what that means is that it's primarily used by those who have a license to use it, which can primarily be used in more larger farming lands now, as we have more an industrialized world where we have big farming lands and big corporations that take part in that. In the US, Paraquat does have now also some interesting characteristics that try to prevent it from, going to the general public and leading to poisoning.
Sorry, Natalia, are you moving the slides or no? Because we can't
No,
see them move. Oh,
no,
you haven't moved.
nope,
Okay, great.
nope, nope. This
Great.
is all me just talking.
Okay, okay. I
Um,
just wanted to make sure that we're not missing the slides. Can
sure,
everyone see
sure.
the slides? Because I got a comment here saying slides are not visible. Sabel देखी रहा था वो slides?
Yeah, you can see it.
Okay, thank you.
Yeah.
This
Okay.
is visible.
Okay, yes, continue. Sorry about that, Natalia.
No, no, totally. Please interrupt if there's any questions, or I'm always here for it. So, and as I was saying, there are some characteristics that we try to now put in Paraquat in order to prevent it from being, leading to unintentional ingestions, which would be adding a blue dye to it to kind of help it distinguish from other products, or also giving it a nasty smell, also just to give it as a warning sign. Also adding an emetic to it, which it will also, if someone does unintentionally ingest it, hopefully to have some of it leave the body as well. This is the chemical structure of paraquat and its sibling diquat. So these are bipyridal compounds. So with the formula of 5 carbons and then also 4 hydrogens and 1 nitrogen, and then it comes with these 2 rings. So paraquat, it is more widely used than diquat. It is also more poisonous than diquat. And actually, over the years, diquat has now also been co-formulated with paraquat in order to bring down the concentration of paraquat and hopefully make the substance itself in total less toxic. I'm going to be spending most of my time talking about paraquat today. There are some subtle differences, but the mechanism of action is very similar between the two. So let's talk a little bit about the pharmacology. I think this is a very important slide and a key understanding of how this poison presents itself in our body. So I would like to bring your attention here. You can see my arrow. So paraquat enters the cell, and that's through passive diffusion. And it actually, once it enters the cell, it enters into its oxidized form. And then it is reduced by NADPH if it's available in the cell. And then you end up going, also if you have oxygen that is available to you still in the cell, then it turns into these superoxide reactive species that undergo different processes that lead to more reactive oxygen species that end up causing oxidative stress and also injuring the lipid membranes within cells, including the mitochondria, which are the energy houses in our body. So this is a very important process that we also call redox cycling. So as long as we have paraquat available, we have NADPH available, we have oxygen available, and some of our enzymes, this can continue to reoccur. And as you can imagine, in large ingestions, then you have large toxicity with this. Then, like I said, and at one point, if you have a large ingestion, we have these NADPH available, we have oxygen available, but at some point it's going to replete, or I should say overwhelm the system, and you won't have any more of the NADPH, or you may not have the glutathione present that helps get rid of some of these oxygen species. So that's where some of our, maybe some potential, treatments may come into play, which are here written out in red lettering as well. Just to have over the years, thinking about what happens in the cell, this is why there have been different proposed treatments for this poison. And I should mention here as well, so after you have all this oxidative stress and also the cellular breakdown, and at that point you also have, you can recall, neutrophils and macrophages that end up coming to this area of destruction. And then over time you can have fibrosis and chronic changes that happen in the tissues that are affected. Pharmacokinetics and toxicokinetics are very important in understanding toxicology, of course. So if for a paraquat, if it's absorbed or taken in as an oral ingestion, then there is rapid GI absorption that occurs. Less so when it comes to skin or also the respiratory epithelium, unless you have prolonged, in prolonged contact with the surface of the skin or also the respiratory epithelium. But when it's ingested orally, then there is rapid GI absorption, and it enters the plasma and peaks at about 1 or 2 hours. Okay. And then it rapidly is distributed to the tissues, and that includes the lung primarily, also livers, kidneys, muscles, and that occurs within about 6 hours or so. And after that, it is quickly then re-enters the plasma, actually, and then goes to the kidneys, where it is about 90% of it is actively secreted as an unchanged drug within 12 to 24 hours, just because this is not metabolized. So these are very important things to think about when we are also having someone that's coming in and how they're presenting, and also how we may interpret our diagnostic testing, which we'll talk about. The pathophysiology of acute poisoning, and again, this is in the acute setting. You can have, so as you imagine, it enters the GI system and it causes direct cytotoxicity, and it will lead to GI necrosis. And with this, series of events happen where you can also have third spacing of fluid from this process. It also enters the vessels and it'll cause direct vascular injury, which that can also lead to hypotension if your vasculature is not functioning appropriately. Or as we had spoke about, it can also go into, and it usually does, go into the lungs where it concentrates, and it can cause direct toxicity there as well and lead to this acute pneumonitis. And with these processes, you can have also direct toxicity within the kidney itself, where it is eliminated. Also, with the prior process that we spoke about, thinking about third spacing or also malfunctioning of the vessels, you can have profound hypotension and a shock state, where you can also then have a glomerular injury, and because of this hypotension in the kidneys. And that leads to multiple processes that can impair kidney function and also impair the elimination of paraquat, where you end up also having a larger problem with your question of how can you even get paraquat out of the body if you are eliminating its primary source of elimination. Here are multiple clinical manifestations. When I'm thinking in my head, I'm going from, top to bottom when I'm doing a history and presentation with a patient. And these are some things that you want to look out for. I'm not going to list all of them, but, you can definitely have irritation to the mucous membranes. You can have irritation to the eyes. You can have this conjunctival pseudomembrane as well. You can eventually have heart failure if you're thinking about a profound hypotension and shock state as well. As we talked about the lungs, you can have that acute pneumonitis that then, as we recall from the pharmacology portion, is that once you have that inflammation over a prolonged period of time, the neutrophils and macrophages come in, and you can end up having this fibrosis as well. And that will lead to the ARDS and fibrosis. GI system, usually early on when you have these ingestions, you do have the nausea, vomiting, diarrhea, abdominal pain, but down the line you can have also more of this. You can have even esophagitis that leads to a rupture, which can lead to a pneumothorax that I also listed under the lungs. We spoke about how from the kidney side, you can have kidney injury from direct toxicity or also profound hypotension and shock state. For hematology, you can have hemolytic anemia. From the skin side, you can also have, after you have prolonged contact with the skin, you have ulceration and also desquamation. And this also, paraquat also does distribute into the muscles, and you can also have direct toxicity there, and you can have rhabdomyolysis. So diagnostic testing, the most important thing, of course, is to, again, have a heightened, suspicion for this diagnosis. So you're thinking about, you're asking your patient about, history of exposure, and then you're also cueing in onto those clinical manifestations that we just spoke about. The best test would be, of course, to have a blood test in a paraquat concentration. However, this is not widely available here in the US. It'll take several days. You have to send it out to a research laboratory, and it takes days before this comes back. And as we spoke about, this can happen, this poison and this process happens pretty quickly in patients. So really having that history and that looking at those clinical manifestations is very important. But also we have dithionite testing that is available to, most places nowadays, but still it can be, it's not always available everywhere, but it's a very interesting test where you have dithionite or hydrosulfide here as a structure kind of listed for you. So what you end up doing is you put either the urine or you put plasma and you mix it with an alkali solution. So you can do potassium hydroxide, for instance, that I listed here. And then you add in the dithionite test, okay? And this is a reducing agent that's going to then put paraquat in its unionized form, and you can then have it in the unionized form is a colorful form, which you'll either have blue for paraquat or you'll have green for diquat. The darker the color, the suspected, the higher the concentration, okay? So before we even talk about treatments or potential ways to support our patients, we do need to say that, generally prognosis is very poor. And it's, very unfortunate and very devastating. And, over time, there have been multiple, prognostic measures or tools that have been, studied in order to decide whether do we choose, to go ahead and do these advanced measures for these patients, or do we back up and say, this patient, the outcomes we suspect are going to be very poor. Let's say the patient came several hours after having this poison, right? Ingesting paraquat, and there are multiple markers that suggest he's not going to do well, he or she. So at that point, we will start to discuss, comfort cares, and also having the patient spend that time with their family, and making them comfortable by giving them pain medication or other measures, just to make to respect their life and not to advance if we feel this is not going to be helpful in the long run. The best way, the best predictor that we have is really also the dose of ingestion. Unfortunately, it's not always known. So in adult human, the estimated lethal dose is about 30 milligrams per kilogram, which that equates to about 3 to 6 grams of paraquat ion, which is about 10 to 20 cc's of 20% solution. So really a teaspoon is a lethal dose for these ingestions. And there is a classification that is available as well. So talking about mild or subacute, which is about less than 20 mg per kg. At that point, the patient may be asymptomatic or may just have more like nausea, vomiting, some loose stool, but is overall suspected to do well. From a moderate to severe ingestion, that's about 20 to 40 mg per kg. And at that point, you have a more kidney injury, more hepatic injury, and you can also suspect that there will be lung injury and also down the line fibrosis, which the patient can die from as well. And then there's fulminant paraquat poisoning, which is greater than 40 milligrams per kilogram. And these patients, typically they reach the state where it's multi-organ failure, and they unfortunately die within just a couple days. Other tests that we have, so we spoke about the dithionite testing, and this can be helpful with prognosis as well. So if in the urine dithionite test, if it's negative after 6 hours since ingestion, then unlikely a large exposure, okay? So if you can imagine and recall, so we said that if within 1 hour or so, it, reaches the plasma, and then within 6 hours, it reaches, it peaks at the tissue concentration, and then re-enters the circulation to be immediately cleared from the urine or from the kidney, then we can say, about at this time is when we should be suspecting and seeing paraquat in the urine. And if we have it be negative after 6 hours, then we can suspect an unlikely large exposure. But we continue to repeat this test over 24 hours because, some people may actually present with earlier kidney injury than others. You also don't know the baseline kidney function, or you may know the baseline kidney function of a patient and may be low to even begin with. So it may not let the compound out of the body as quickly as others may. So you want to continue this testing over 24 hours. There's also the plasma dithionite testing. So if positive, it is specific for death per studies. If negative, it does not exclude, however, severe poisoning or death. And then we should also talk about quantitative analysis. If you do happen to get the concentration of paraquat, you can use these nomograms that are out there. Again, this is not available to everyone, and you may receive this concentration of paraquat several days later. But I do want to bring this up because this is out there as well. So we have different nomograms. And if you have the concentration, you have the hours since ingestion, then you can go ahead and look at the nomogram. And if it's below that line, then that's about the suspected or expected percentage of survival in that particular patient. There's also SIP, or the severity index of paraquat poisoning, that you can calculate, which is where you take the plasma concentration and you multiply it by the time since ingestion. And if it's less than 10, it'll predict survival. Between 10 to 50, it will predict death from lung fibrosis. And greater than 50, it'll predict death from circulatory failure. So just another tool in your toolbox in order to help discuss prognosis or determine if you need to go ahead and treat. And then, where we don't have these tests widely available, we do have, if we do, we have some laboratory tests that we use on a daily basis, and that can kind of help us cue in to a large ingestion and possibly, a poor prognosis. And that includes blood gas, thinking about metabolic acidotic state, CBC, which can also lend to a hemolytic anemia state, BMP if you have significant electrolyte abnormalities because you're having nausea, you're having vomiting, or diarrhea as well. So looking at that as well. You can have pancreatitis, so looking at your lipase. And then of course we spoke about how this also goes into, the paraquat goes into the liver. So you can look at LFTs and see if there's any direct toxicity within the liver as well. There have been studies out there that have also, looked at kidney function, which is very important as well. As we spoke about, paraquat is eliminated through the kidneys. So you can look at the rise in creatinine as well. So if that's rising, or if cystatin C is rising, then you can suspect that the kidney is not functioning as well, because it also eliminates these products from the plasma. So if you have a creatinine increase less than 0.03 over 5 hours, then that can predict survival, because it's saying that the kidneys are still functioning really well. Or if it's greater than 0.05, then you can predict death. Cystatin C also, if it's greater than 0.09 over a specific amount of time, over 6 hours, then that can predict death as well. Other measures we can have is also, there are studies out there that have looked at CT of the lung, and some have said, a proportion of the lung affected, if it's about 11 to 12%, then, or less than that, then they suspect that survival is, likely, versus other studies have said less than 20% survival is likely. So it's not as consistent. But if you do see a progression of consolidation, fibrosis, pleural effusion within a couple days, then you can suspect that the prognosis is poor and you're already having those chronic changes happen within the lung because of severe toxicity from paraquat. So again, you have all these measures in place to think about whether you're going to talk to your patient about, advanced measures versus choosing, end of care goals, right? And talking about that end of care cares. The management that we do have, for any patient, and especially when it comes to paraquat poisoning, is of course talking about resuscitation and supportive care, which we'll talk about. And then also trying to eliminate or prevent absorption of paraquat in the body through GI decontamination, or try to remove it from the plasma, which would be from extracorporeal removal. And then maybe some other potential antidotes as well. I should say that, it gets confusing because there are definitely case studies out there that have seen, that patients have done well with these. But generally speaking, there aren't great human studies to support and to make firm recommendations for these treatments when it comes to paraquat poisoning. So that is just something to keep in mind. And these don't always work, but they are available, of course, to you, or so if you have the resources in place. So talking a little bit about resuscitation supportive cares. Of course, if your patient, has maybe is already on the ventilator or, has already baseline poor lung capacity and needs oxygen at baseline, of course, you should continue giving them oxygen. But as we talked about in pharmacology, if you can recall, we have, this, if we constantly have this oxygen supply, we are allowing for more of these reactive oxygen species. And then causing more toxicity. But the goals in some studies, they say, you want to just make it sure that the hemoglobin saturation is adequate, but not to give too much oxygen, and where you're giving, leading to 100%, right? Not patients can do very well at lower numbers. And then that's also your hope that you can eliminate or prevent further reactive oxygen species. Intravenous fluids, of course, we talked about this becoming a hypotensive state, a shock state. So you do want to give fluids, but keeping in mind that you do not want to overload because you also have this third spacing that does occur in the body, as we spoke about, and you don't want to lead to a hypervolemic state. And then, of course, you want to have, keep close watch on your patient, closely monitor with daily labs and imaging and further support based on those as well. GI decontamination. So activated charcoal is recommended for all ingestions, especially if they're less than 2 hours. This is where you get the most kind of the bang for your buck, the most it's the optimal way to kind of use charcoal. So I do want to note, though, there is bentonite clay or Fuller's earth. So if you all remember earlier, we spoke about how, paraquat, once it's, sprayed onto like the leaves, you have that absorption and you kill off the plants. But when it enters the soil, it goes into an inactive state. So this is kind of where the thought process came with Fuller's earth or also bentonite clay. There were studies out there that tried to use that in order to prevent absorption and inactivate paraquat. But studies have showed that activated charcoal, it works just as well or even better than Fuller's earth and bentonite. And so the recommendations are, for activated charcoal at this time. Gastric lavage has not been helpful just because of how quickly it's absorbed, through the GI system. But it just to kind of remind you, paraquat is also now at times co-formulated with an emetic. And so that's just another form of GI decontamination that may occur early on in the process too. Extracorporeal removal, if you have, the means for this, the resources, then wonderful. Hemoperfusion, hemodialysis, the goal is to really just remove paraquat from the plasma. Studies, however, don't show an overall mortality benefit when you look months out, but that is something that is also, available to you. And again, case reports may show something different too, but there's just not enough, there's not human studies to consistently to show this. And then other risks that you want to keep in mind, of course, is also with CDL placement, metabolic disequilibrium that can occur, and also increased clearance of any antidotes if you wish to use them. So potential antidote therapies, there are many out there at this point, kind of trying to target the different processes that we talked about in pharmacology. They generally fall under immunosuppression and also antioxidants. So thinking about immunosuppression, there are studies out there that are looking at glucocorticoid with cyclophosphamide. They've looked at this for now a couple of years. This is, with the intention of suppressing, right, this inflammatory state that leads to all these, immediate and also chronic changes that can lead to death. There was a Cochrane actually review recently that looked at all these studies, and they said, there's with low certainty evidence that it may slightly reduce mortality, but however, it's again unclear at about the 3 months point. And they also recommend, the reason they also looked at all this and all these studies is because of, when you're talking about immunosuppression, you're also talking about increasing the risk of infection. So, that's just something to keep in mind. And there are many, there are antioxidants out there that are also being used, including vitamin C, E, and then NAC. NAC, which we use for Tylenol toxicity, but it can also be used for other toxicities where your liver is involved as well, or where your glutathione needs to be repleted. So NAC is also a great option as well in this case. So prevention, there are many ways to help prevent, toxicity from paraquat. And I think this is very key, especially when we're talking about a toxicity, a poison that really is devastating. And like we spoke earlier, Dr. Carell mentioned how it's really a death sentence. In many ways. So talking to the public about this, having this public education is very important. And then, having this access restriction that we're already seeing in multiple countries. And then also promoting safer alternatives as well. There are many countries who have now banned paraquat, are looking to other methods of controlling the weeds and the grass, whether that be by mulching or doing other products, out there that they're also using. Some are using diquat, which I should say is also it works very similarly, but there are different methods of also approaching weed and grass control, and other countries have looked to these instead of using. So joining this global initiative from Goldfrank's, so I thought this was a great statement and just wrote it here. It's, ultimately the key focus is reducing deaths from paraquat poisoning is to ban its sale, or at least highly restrict its availability to commercial operators, which is supported by outcome data from a number of countries. Some of these countries are like Sri Lanka. So in 2010, they had banned paraquat, and actually paraquat poisoning was like the leading pesticide poisoning when it came to also suicide. So this was a very, very important measure, and they've had great outcomes from that standpoint as well. China had also banned paraquat as well, and their numbers, and especially their suicide numbers from this, had also come down. And then, unfortunately, there are still, countries that are using it, and that they have significant, poisonings and suicide poisonings from this. And that includes, let's say, like Malaysia as well, that I was reading. But and globally, we still have about 150,000 to about 160,000 annual deaths from paraquat poisoning. So these are very key things to keep in mind. And I think it really does start with also having these discussions as we're having today, and really bringing awareness to these poisons that are out there. And as toxicologists and doctors, I think we play a very important role in preventing this, continuing forward, and really taking care of our patients from also a global perspective. So that is it for my talk. I would like to thank you all very much for having me, and these are my references, and I welcome any questions, and thank you.
Thank you, Natalia. That was really, really fantastic, and a really good approach and overview summary of how you can think about paraquat poisoning. There are a lot of challenges, I think, in our country is that one, diagnostic wise, we don't really have a wide availability of diagnostics. That's a big problem. So a lot of things are based just on history, and sort of symptomology you have to kind of see. But I really like that normogram. I didn't know that existed, and you really need you need the plasma level
Yeah.
to use that normogram. That's one thing. And then in this country, I know there was a question around sort of how, is it banned or not? So we have one of our colleagues from the Poison Center, Dr. Rakesh Gimire, has been working on banning pesticides in this country, like highly hazardous pesticide. And from what they had done in 2022, there was a study done that showed, there are not too many cases. Like diclovers was a common cause of death in the country, as well as aluminum phosphide. Paraquat was not really seen in their study, but in our poison center, we have probably seen in even just 1 year, probably 3 or 4 cases of paraquat
Mhm.
who have died. And the country has not fully banned paraquat as of now, but it is kind of controlled to commercial users. So that's kind of where we are right now. But this is a really important herbicide that is killing a lot of people, even just with a teaspoon, like you said. Does anyone else have any questions for Dr. Natalia here?
Hello, namaste, good morning, and happy Thanksgiving.
Oh, happy Thanksgiving.
I'd like to ask one question. Is there any scoring system that you use in the ED, the patients who come with paraquat poisoning?
Yeah, and I think that's a great question. Actually, we do not have even a protocol in place, even if we were to call the poison center. So we really don't have even a scoring system ourselves. It's truly, based on the anything outside of what was discussed in the presentation. We have the dithionite testing, and here we can't get these Paraquat concentration for days. So this nomogram, as great as it is, it does not really apply here for us as quickly as we would like it to. So definitely just kind of what I had mentioned here. And I've seen at other poison centers too. They've also have this dithionite testing. And so really from our standpoint, it really comes down to this and also the, how much ingestion, right? And then we spoke about that being kind of the best predictor. And then the dithionite testing is really what we have available.
Thank
Natalia,
you.
there was
And
a
I'd like to
question.
ask.
Go
I'm
ahead,
sorry.
Mahesh.
I'd like to ask another question. Uh, when you or any other physicians use the nomogram, does that indicate the use of immunosuppressants like steroids and cyclophosphamide?
I think it will when anyone's using like dexamethasone or methylprednisolone and also considering cyclophosphamide with that. I think you're talking about, definitely kind of the time of when the patient presented. And really, it's really a discussion. And I think actually many physicians will have different approaches to it. And what they feel comfortable with. So if you're having, a young patient that's coming in within a couple hours and you have, these prognostic testings that, even may show poor prognosis, right? I think some physicians may still go ahead and kind of throw what we call the kitchen sink, which like all the treatments that we have available, we'll still try to, do everything for the patient. Whereas others may, have more, a different approach. We have like, let's say a palliative care, actually emergency medicine physician who's really good when it comes to looking at organ failure and prognosis, even just outside of Paraquat. And maybe someone that, looks at all this and will be like, I think we need to proceed with like end of care, like discussions. I feel, this is kind of the best way to do this approach. It's unfortunate. I wish we can all have like a standardized way of approaching this, but I think these, I should say we don't have, I guess, a scoring tool that we say, hey, we're going to do cyclophosphamide and steroids. So it's just more of our kind of, I would say, physician discretion as well.
Thank
Right.
you.
Thank you, Natalia. There was a question around like the most common cause of mortality in this patient, and I think we have kind of seen that it's multi-organ failure. It seems like, but pulmonary is probably what's what ends up killing people. And I think in the same line, there is a question around managing respiratory distress in this patient.
Sure.
Maybe Natalia, you can kind of talk about like escalating oxygen therapy, maybe in this patient.
Sure. Yes. So if someone does, let's say, survive those initial couple days from, and they don't have this fulminant like multi-organ failure state, then after several days you can see more of this chronic changes like the fibrosis and lung injury, and from which the patient can also pass away from. So it's just you start to see it a little bit differently. If you're in even in dicot, it's very interesting. Actually, you start to see more of a brainstem hemorrhage later down if you actually pass through and you don't you don't die from that immediate multi-organ failure. So you just see these in different stages. So unfortunately, if you're, a physician, you might think, oh, they're not in this multi-organ failure state, we're out of the clear. But then you start to also continue to monitor this patient and you see that they develop respiratory distress. And then you look at the CT lung and you see all this fibrosis, and it becomes very concerning from that standpoint. And in terms of oxygen therapy, I agree. I agree if the patient, does need, oxygen, you do want to give it to them. I think the general approach to it is just with an understanding of the pharmacology is trying to, give them, I've seen like studies where they say, oh, hemoglobin concentration of like 85% should be okay, just not to reach that 100%, unless you're talking about supportive cares. And at that point, you want to make them as comfortable as possible. And you do want to give them oxygen because they're going to be, very distressed if they're not having oxygen in place. So you do want to give that to them. You want to give them morphine, for dyspnea. You want to give them all these measures. So I don't think the answer is not to give oxygen. You definitely do, especially if someone comes in and they're already requiring a vent and oxygen at baseline. You don't want to take that away from them. They already have poor lung capacity at that point, and poor lung reserve. So you want to go ahead and give that to them. So that's kind of the approach when it comes to oxygen.
Great. Thank you, Natalia. Are there any other questions? We have time for one more. If not, there is a feedback form for...
Wait,
Yeah, go ahead.
just wait.
Deepika.
Actually, I had asked one question to Dr. Natalia that how often she used to face such cases at her hospital about the paraquat poisoning.
The question is, how much do we see it here in Wisconsin?
Yeah, how frequently you get such cases?
Yeah, no, we actually do not see this often. I would say actually these were more common in about this 1980s or 1990s. And actually there would be toxicology like fellows that would travel outside to the countries to do, there was one program in Arizona I spoke with the toxicologists there. They would send their fellows, let's say to Taiwan, where they would see paraquat poisoning every couple days and deaths from paraquat. But fortunately, we are actually not seeing this as common at all here in the United States anymore. It was more common in the late 1900s here for us. But the restricted use has really helped for sure. But this is something that we still need to know as both toxicologists and emergency medicine doctors, because these cases still do trickle in every so often. But Wisconsin here, for instance, doesn't even have a protocol right now in place for this. So it depends on which state, I should say, and where you have more of this farming and commercial farming, where you'll actually see more of these exposures from those who are licensed workers working on these large farming lands that have the highest exposure risks, because we just don't see it anymore here, kind of in the general public.
Right.
Thank you.
Vijay,
Thank you, Dr. Natalia.
And Vijay, you asked if we have this poisoning in Nepal. We definitely do, because we are seeing it at our poison center. We're getting calls on paraquat, not too, infrequently. Now, it's not as common as other, sort of herbicides and other sort of compounds that cause mortality in this country, but it still exists. So this is a really, important one to just kind of know. So, I think that's where we are. Please, there's a feedback form for you all to fill out that Anjana has kindly put in there. As a reminder to everyone, our Poison Center is available to you 24/7, and the phone number is 450-2011. So you can always call, and we have a great group of international and national experts that sort of help you guide. Just if you're at a district hospital, you don't know what to do, like to send the patient somewhere, or even where to send, or if they can just be monitored, our team will kind of continue to follow them along with you. So please utilize this service as we have this available. And we have a social media account on Instagram, PIC Nepal, so you can follow that for kind of monthly webinar announcements and things like that. And we're really thankful to Dr. Natalia for giving us her time today. We're thankful to you all for joining, and sort of our PIC team who's also joined here. We're thankful to them as well. So that's about it. We're gonna have this on YouTube, and we'll send the link to you guys as well on your email. And that's about it. Thank you, Dr. Natalia.
Thank you, everyone. Thank you. Have a great day.
All right, everyone. Take care. Have a good evening.
पहिला थिएन यस्तो राम्रै थियो